So thank you for everyone for joining kind of promptly on time. Just waiting for Sarah to join us, who's our speaker this evening. So she should be joining very shortly. Hiya. There she is. She was hiding behind the behind the screen. Okay, so thank you, like I say, everyone for joining this evening. So we're going to be talking about navigating blended diets in the community setting. And we've got a great speaker this evening. We've got Dr. Sarah Durnan, who's a clinical academic dietitian. She works in the UK at Nottingham University Hospital, NHS Trust. And she's also an honorary assistant professor within the Centre of Child, Maternal and Family Health at the University of Nottingham. She's done lots of research into blended diet, so specifically exploring families' experience of blended diet, and she's leading a review of the British Dietetic Association Practice Toolkit, which hopefully is due out for publication next year in 2026. So I'll hand over to you, Sarah.
Great. Thank you, Lucy, for that introduction. So as Lucy said, I'm going to be talking to you today about navigating blended diet in the community setting. So an overview of my session today, I'm going to provide you with a little bit of background and context about blended diet and discuss the benefits and challenges, so using my PhD research as an illustration. Introduce the BDA practice toolkit and the advice that we gave through that, and provide practical guidance for starting and supporting families who are using blended diet in the community setting. So although I will touch on blended diet in the hospital setting briefly, this webinar will be followed by a second session on the 10th of December by Ruth Stanley from Newcastle. She was also one of the co-authors of the BDA practice toolkit back in 2021. And she'll be doing a more focused session on the acute setting. So nice picture here of a blended meal, and this is the kind of consistency that you might end up with after starting blends. And blended diet has become increasingly popular over the past decade in the UK. The numbers of children and young people that we have living in the community with gastrostomy tube feeding is increasing. It's really difficult to work out even how many people are tube fed in the UK. We don't now have the bans data that we used to have from BAPEN, but a current estimate is about 84 per 100,000 in England. And it costs a lot of money, although it's relatively small numbers. The NHS allocates over 200 million annually for commercial enteral formula. And commercial enteral formula is the first line. It's normally what happens when children are discharged home on a tube feed, and they're prescribable borderline substances, and you will all be very familiar with those in your practice. They're sterile, they're ready to hang, they always have the same colour, they're a uniform consistency, and we know exactly how many calories there are and how many grams of protein in a set number of mils, and the viscosity is always the same as well. So what is blended diet? Blended diet is everyday food that's blended at home. So it's the same food that you and I would eat orally that can be blended with a liquid to a consistency that can be given through the enteral feeding tube. And although we use the term blended diet, actually that is an umbrella term for a broad range of practices. And some families may be using that as the sole source of their child's nutrition, or they may be using it alongside a commercial formula. We have plenty of families, for example, who will have breakfast, lunch, and dinner blended and then an overnight feed using a commercial formula, or they may be using the commercial formula as the base for their blend. And then you get families who perhaps only use blended diet on occasions and special occasions as well. So there's this continuum of practices, and that actually makes blended diet quite hard to study. It's quite difficult to compare it to a commercial formula because there are so many variables. When we were doing the blended diet practice toolkit back in 2020, we did a piece of scoping work with the DISC group of dietitians in the UK, and we estimated that 20% of their paediatric caseload are currently using blended diets. That was a few years ago now, and we know that the interest is still increasing. We still get lots and lots of queries about blended diet through the BDA, so that may be higher still now. And I know we're a paediatric focused audience, but we are noticing that there's more adult tube-fed patients who are showing an interest in blended diet too. So this is looking, this picture is provided with consent, but this is a slide showing the benefits of blended diets. And this has come from my PhD research. So I interviewed families who'd chosen to use blended diets to try to understand from their lived experience what they perceive the benefits to be. And the benefits could be divided into both social and emotional, and also physical benefits. For the families that I interviewed, management of the symptoms that the adverse symptoms that they associated with the commercial enteral formula was the motivation for initially trying blended diet. And then when they tried blended diet, they found that there were beneficial effects. So they found that the food stays down. These are quotes from the PhD research. The food stays down, so they were able to reduce the symptoms of reflux, retching, and vomiting, and the families found that that reduced even with a matter of days or weeks. They found that symptoms of constipation and diarrhea resolved. So for some of the families, they'd had real problems with constipation, others diarrhea, and some had had a combination of the two, but following blended diet seemed to normalise bowel habits. The families found that their child had a better pattern of growth, so improved weight gain. The majority, they had been really struggling to put on weight, and that had been a constant battle and constant source of worry. And they found that their child was able to put on weight. For a few of the participants, however, their child had been really puffy and bloated previously on commercial formula, but they found that actually perhaps they'd been overfeeding their child on the commercial formula. And the parents really perceived their child to be generally more healthy, so they didn't seem to have the coughs, colds, common illnesses. They weren't going to hospital as much as they had been previously on the commercial formula. They found that their child looked better, so they had visible improvements. They commented about having glossy hair, skin seemed brighter, and their fingernails grew. And they found that the child, people who didn't even know the child were commenting improvements, that they looked better. School staff seemed to think that they seemed more happy and engaged as well. So that for the parents, this change in feeding really transformed the health and well-being of their child. And then reflecting back on their experiences, they also noted some of the social and emotional benefits. So it was interesting that the parents talked about the commercial formula in almost like a medicine. So they would talk about doses and mils and timings, whereas they spoke about the blended food. They often called it real food, and they would talk about breakfast, lunch, and dinner. And as a result, they also felt that that was more like a parenting role as opposed to the feed, which was a nursing role and part of a kind of a medical intrusion that all this complex health needs had on their home life. And they really enjoyed actually being able to provide food for their child and to buy food from a regular shop. And some went as far as saying it's actually a human right that we should be able to provide food, and to say that they felt that they wouldn't feel happy having the commercial formula themselves. Others definitely saw a place for commercial formula, and there was variation in that opinion between them. The families really enjoyed that they had lots of different choice. They could choose from a vast array of different food ingredients to go into the blends. They could adapt the fiber content. They could omit certain foods. They could personalize their child's diet to fit their needs and preferences. And there were some cases where the child themselves could choose the foods that were going into their blends. But the challenges for the families were definitely the increased time and work. So using blended diet requires planning, shopping, preparing, cooking, storing, and it may require new skills and knowledge as well. So a lot of families were investing time trying to teach themselves how to do blended diets. And a lot of them were using networks online as well, working with other families in terms of how to get started. The Using blended diet transfers the cost of providing nutrition to that child from the NHS to the families. However, families really found that they weren't comparing the cost of providing a blended diet versus the cost of the commercial formula. They were comparing it to the cost of providing the food should the child have been able to eat properly as well. And a lot of them really actually enjoyed being able to provide for their child. Um, Overwhelmingly, the biggest challenge, though, was accessing professional support. Parents reported huge variation in practice, so they perhaps would have a supportive dietitian, but the gastroenterologist wasn't supportive, or the nurse wasn't supportive, or vice versa. And that was really difficult, and particularly difficult when transitioning or moving from um, one care professional to another who may not have different skills and experience with regard to blended diet. So I'm really excited that so many people are here on this webinar today learning about blended diet. Hopefully we can improve that. So how do we start blended diet? And I guess we've moved from a situation where blended diet, we used to encounter it when families went off and found out about it themselves, and often presented at our clinics or on our home visits saying, I've been doing this, I've already started doing this for a while and it's going great. But now with the new practice toolkit that came out and the policy statement in 2019, there's been a bit of a shift. So actually, as dietitians in the UK, we are the BDA recommendation is that dietitians have a duty of care to actually offer it as a choice to families where there could be particular benefit. But as I've said earlier, the blended diet is a huge array of different practices. So where do you start if you're offering it as an option? And this is really going to be tailored to the individual, and it would a transition plan would need be needed depending on the person's age, medical history, and how long they've been tube feeding for as well. So, for example, if you had a child who'd been tube fed since birth, you could actually start tube feeding using blended diet from around 6 months of age. So, in line with complementary feeding guidelines in the UK, and then introducing allergens within the first year. And actually, that is a really good way of getting going with blended diet. You're introducing those puree foods, and you've also got families who are often peers with children of a similar age, and they're working through those foods together often. So long as it's a puree approach to weaning as opposed to baby-led. So with an older child or a young person who's weaned orally, this can be a little bit easier. You might be able to go a little bit quicker because that person has already been through a normal weaning process. You're likely to know whether they're allergic to certain foods, and they're likely to have established likes and dislikes. And actually, that might be part of the motivation for using blended diets. So, for example, recently worked with a family where the child had a neurological condition. They had a tube placed in later life around 14, and they really missed being able to share a meal with their family. So that was part of the motivation behind using blended food. With an older child or young person who's been tube fed since birth, you need to be a little bit more careful because they're likely to have not been through a normal weaning process. So you would again gradually want to introduce foods and go quite slowly. As I've mentioned, the families really found that actually feeding it felt quite medicalized. And even if we can just change the way we talk about enteral feeds and enteral feeding plans, maybe we can make it feel more normal to families. So often we will talk about feeding regimens. Could we talk about meal plans instead of it being 300 meals at 8 a.m.? Could we talk about breakfast? And that is about shifting from thinking about it as a medicine to thinking about it as food. And that can take a little bit of getting your head around, particularly as a dietitian, but also for the families if they've had a tube-fed child for a long time. I find that it really helps having a plated meal approach when starting out. Families can see the food and start to gauge healthy, age-appropriate portion sizes. Um, and you've got to fit this into the family's life and try to make it as little time and work and effort and part of their normal routine. So a really good place to start is by assessing what the rest of the family eats first, giving that general healthy eating advice. And maybe you want to tweak that to the individual needs of the families, but that can be a great individual needs of the child, but that can be a great starting point from which to work from. So yeah, really thinking about breakfast, lunch, dinner, and some healthy snacks as well. And I often get asked about volume tolerance as well. So sometimes you don't need breakfast, lunch, dinner. Sometimes you need breakfast, mid-morning snack, lunch, mid-afternoon snack, dinner, supper. So you can have lots of small bolus blends. So healthy eating advice. And there's always been this question around blended diet as to whether it is nutritionally adequate. Asking the question, is blended diet nutritionally adequate, is like asking the question, is food nutritionally adequate? It depends entirely on the food choices made by the tube-fed child's family. It absolutely can be adequate, and where we have a role as dietitians is to counsel that family on healthy choices and adapting the diet to be as healthy as possible. So we know that in the UK, we have the Eat Well guide and the advice around that as to how we get a healthy and balanced diets. But we also know in the UK that adherence to the Eat Well guide recommendations is pretty poor. So you really need to assess where you're starting from, what the family's knowledge around nutrition is. And this is an opportunity to improve not just the diet of the child, but also the whole family in quite a holistic way. Really important not to forget hydration. So I've got a slide focused on this. So there's general advice on how much a child should drink, but in reality, we know that the fluid requirements of an individual depend on age, gender, body size, activity levels. It might depend on how warm it is as well. And some medical conditions will affect the amount of fluid needed as well. And often our children who have complex health needs, who have enteral feeding tubes, maybe on medications that affect hydration, such as those used to control excess drooling. And it's tricky as a dietitian when you're starting out to know how much fluid there is in blends. So we have suggested within the practice toolkit to work on the assumption that blends are 70 to 75% fluid. What actually happens in reality is that families start off making blends quite thin, so there's more fluid added into the blend. As they become more confident, the blends become more like that slide, that first slide, so quite thick. Um, and we think actually the thickness of the blend is part of the reason why it has that beneficial effect on reflux, retching, and vomiting. So being thicker and less liquid, it can stay down and not slosh around in the stomach. So actually, we probably don't want to make the blends thinner. It might be worthwhile making sure that you're giving the fluid as extra flushes. Some of the families find that they they get better tolerance if they give that as a separate, almost like thinking of a separate drink with a meal or just before a meal. And remembering as well that all of the water flushes given before, after, and between, they count towards fluid intake. Any large volume medications also contribute. Um, and rather than trying to absolutely work out every meal in a blend, maybe teaching families to monitor for signs of dehydration and adjust and give them the flexibility to give a little bit of extra fluid if the child seems dehydrated. Okay. A note on fibre as well. So we suspect that the introduction of this huge variety of fibres, prebiotics and probiotics may be the reason behind some of the benefits to bowel health. But also we need to take care when introducing fibre to children, young people who've potentially not had fibre. Often some of the steps that we take if you're not tolerating a commercial enteral formula, maybe to go on to extensively hydrolyzed or feeds that don't contain fibre. And if the child is on a fibre-free feed, we need to gradually increase it and make sure that we're giving enough fluid alongside. You might want to manage those expectations in the family and warn them that they may have some minor gastrointestinal changes, abdominal distension, flatulence, changes in bowel habits, and they may take a couple of weeks to settle down as you introduce the feeds. They may also need a medication review. We find that families who have who have problems with constipation and are on lots of laxatives may need those reduced down as well. And then when we're thinking about blended diet in the community setting, we need to think about the type of tube and how we're going to manage that tube in the community and trying really hard to minimize any admissions to hospital. There was some concern initially with blended diet that we might end up with lots of tube blockages and what the impact of that could be. Um, we don't find that the tubes block in practice. I've had very few feeding tubes block. And usually it's due to a raspberry seed or something really starchy and stodgy, or due to the medication. And interestingly, there's been a recent study by York University, and they followed 180 tube-fed individuals, roughly half blended diets, and they found no increased incidence of tube blockage in those participants. But to err on the side of caution, it probably is sensible to make a plan about what would happen were that tube to become blocked. That's probably a good thing to do in a community setting anyway, so that people know what to do in that instance. The benefits of a balloon retain tube is that it is can easily be changed in the community. And the benefits of having a wider bore tube, it might be easier to administer the blends through that tube. We did say for a long time the guidance was 14 French, but actually when you follow that thread through back to the original source, it was just one dietitian in America who was saying 14 French. So actually, based on our experience as a working group when we were developing the practice toolkit, and from other examples in the literature, and more examples have come forward in the literature. It's perfectly possible with a 12 French or even a smaller tube as well. In terms of the site of feeding, I find the majority of children within my practice are fed via gastrostomy. We did say in the last version of the practice toolkit that we don't recommend use of blended diet in the jejunostomy, and the reasoning behind that was because it's not got the same storage capacity, so it's more difficult to deliver boluses, and you've also not got that protective stomach acid. But we have become aware that some dietitians are supporting people who are feeding blended diet via jejunostomy, but it's just not documented at the minute, and we're hoping to change that via some case studies in the next practice toolkit due out next year. There was initially some concern that blended diet might mean that we end up using a lot more enteral feeding tubes because of that tube blockage. And as I've mentioned, that your tube study did not find that that was the case, and we don't find that in our practice as well. So the families in our community setting have the same provision of ancillaries, giving sets, bolus giving sets, tubes, tube changes, those kind of things, exactly the same as those who were on commercial formula. However, enteral syringes, they may end up experiencing some discoloration, and you may lose the numbers potentially if you're doing lots of scrubbing to get them clean. And some of the families find that they get on better with the O-ring syringes, that are easier to do a administration using a syringe with a push on the end. Question that always gets asked about blended diet is, what kind of blender do you recommend? You absolutely can do blended diet using a handheld blender, really, really cheap and inexpensive. They're easy to use, easy to clean. The down points of that is that you may not have as many options. There may be some of the food ingredients that you can't use because they just won't blend with the handheld blender. So things like nuts and seeds. But actually a really easy way to get started. And for a family who aren't sure if this is actually for them or for a child, a really young child, and you're starting to introduce single purees, then that would be a good option. The mid-range, so that's things sort of NutriBullet, Ninja kind of size, if we were to label them. They're mid-price range, they're not that expensive, they're easy to use, easy to clean. They actually work really well if you're blending meal by meal. They can quite easily deal with that kind of small volume. And you know, a great step up from the handheld option as well. I think in practice, I find that families sort of work their way through them as they're getting started. So usually families decide that actually they want to invest in a commercial grade blender, the really high powered one. So these are things like your Vitamix, your Blendtec, your OmniBlend. They're huge. They can blend pretty much anything. They're really good if you have a family who are wanting to move to batch blending. So if they're setting aside a Saturday and blending everything that they need for that month and putting that away in the freezer, that's a good option. Often they have a self-cleaning setting, long product guarantees, and they're really durable. But they can be really expensive. So we're talking 400 to 600 pounds or euros. So pretty much the same now. And they also are really, really noisy. And I have had some families who are, the child is quite sensitive to noise, who find them quite difficult to have in the house. but definitely worth considering. It's the length of time that the food is blended that helps you achieve that consistency rather than the wattage of the blender. So if you're having a family who are having difficulty getting that consistency, make sure that they are blending for long enough, using whichever blender they are using. So note on food safety, so this is exactly the same advice that you would be giving to somebody who was eating their food orally. And it's really common sense type of food handling. So anybody who works within a food setting should have had this type of training, particularly in the UK where there's legislation around that. So we're talking about hand washing, safe storage of food, so making sure that things are raw and cooked food are kept separately, making sure that things are used within their use by date, and making sure that food is kept at room temperature for a maximum of 2 hours and not longer than that. We probably wouldn't return to a buffet that had been out for 4 hours, so we probably wouldn't want to have that food hanging in a container or in a syringe for that amount of time. Checking that refrigerators are the correct temperatures, and freezers, and the length of time that food can be stored in the freezer or the fridge will depend on the food ingredients that have been used as well. If the blends contain anything like meat, chicken, or previous cooked foods, then it's a good idea to reheat that so that it's piping steaming hot, but then cooling it down to administer through the tube as well. Outside of the family home can be really tricky. So I know I said I'm focused on the community, but I will talk briefly about hospital here because we know that our group of tube-fed patients have complex needs. It is likely that they will end up in hospital at some point. So trying to sit and plan and think about every setting where that child may be fed outside of the family home. For example, that could include nursery school or college. And it really depends on the facilities and the skills of staff at that education setting. And really think about transitions as well. So if they're moving from primary to secondary school, you may need to support them to make sure that they have things in place for their new school year. Hospital or respite care. So what would be the plan if admitted to hospital? And it may be worth considering that different hospitals may have different policies and they may end up in a different hospital depending on what they're going into hospital with. So having a kind of plan B is a good idea. So I mentioned at the beginning that for some families they use a combination of commercial formula and blended diet. Would they be happy moving back to a commercial formula? Are there other products that you could use, perhaps that contain real foods in place of their blends? Is the hospital going to be happy for blended food to be sent in from home or not? And are nurses on the ward happy to administer? And are you happy to have that? The nurse is going to be happy if they're not, if you're not there to administer. What happens? Is there another product that can be used? Because often families say, well, if they're in hospital, I'll be in with them, but they may not be able to. And then eating out on holidays. Actually, I've worked with a lot of families who've been able to have blended food when they are away, or in their local restaurant as well. If they contact those places, they may be able to get a plan as to what they can and can't do. In terms of monitoring, we find that families who are using a blended diet are likely to need more support from their dietitian in the first 3 months while they're getting started and they're getting used to blended diets. I personally wouldn't give recipes out, but some dietitians find that this is a good way to get started. But I would try to work with the family's own recipes and adapting those where possible, because that's more sustainable. In terms of how often we see families, so after that first 3 months when they've got started, we would see our patients within every 3 to 6 months with ad hoc contacts between. This would include growth measurements. We don't do any additional biochemistry monitoring just because they're on blended diets, and we don't give any additional supplementation other compared to the standard practice, unless we've assessed foods that they're eating. If they're omitting whole food groups, we would consider supplementation then. And you really want to be monitoring those changes in gastrointestinal symptoms as well. Is it having the beneficial effect that we'd hoped for? I've seen dietitians try to assess the nutritional content of every blended meal. That is only ever going to provide you with a snapshot, and it's just not feasible. We can't do that. We don't have the capacity to do that. So it's far better to try to think of it as a whole meal and a whole diet approach, and working on kind of balance and making sure that they're getting enough variety. The use of IDSI can be a really useful way to describe the consistency that you need to get through the tube between different care settings. And there's a simple test that can be used that you can teach to families. And asking them to keep a food diary can be a way to assess overall adequacy of the diet in the same way that you would with a child or a family that's coming to you as an oral eater. And a note on variety as well, encourage variety. You We often find that families find a ingredient that blends particularly well and they may become over reliant on it. You may see that cropping up in the diet again and again. A good example of that is sweet potato blends beautifully. And if families start using that every meal, you can start to have children who present with orange hands. Doesn't really cause a problem, but it's that sign that they're using too much of the same foods. Okay, and I have some references there, and then we should have about 20 minutes for questions and answers.
Fab, thank you so much, Sarah. Yeah, so we have about 20 minutes. We have a few questions come in, so I'll read those out to you. Obviously, if there's no more, then we can finish up a bit sooner. This one's maybe more of a statement than a question, but if we allow puree meals for children with special needs to be done in the school canteen or kitchen, why do we not support more schools to use those same meals as a blend via the gastrostomy instead of just using commercial formulas in school settings? I mean, I suppose that depends on the school, doesn't it? And it's quite hard to
Yeah,
give a blanket. Yeah.
yeah, it really does depend on the experiences of the school. Interestingly, we moved from in the first practice toolkit, we talked about risk assessments.
Hmm.
And we realised that actually just the terminology risk assessment makes schools worry because they think, whoa, this is risky. I don't want to get involved in this. But actually, if we move to more of a shared decision approach, and absolutely, if they're blending food and giving it to children orally, they should already have the skills, the equipment, everything that they need, but there's something about the confidence because you're having to administer it via a feeding tube. It feels more like a medical intervention.
Yeah,
And it comes back to that normalizing feeding, even though it is via a tube.
And do you think there'd be any role for like the BDA or dietitians maybe who work in sort of specialized schools um, to do some education around kind of being able to use those meals that they already have available for these
Yeah.
children?
So absolutely. And I know lots of dietitians who've put in an awful lot of work trying to facilitate children being able to have blends at school. And it takes time, it takes work, it takes a lot of trying to support the schools. But what we do find is that schools that start to use blends, and once they've seen the benefits and the impact that it has for that child, they're then more willing to do it again. So but it's just that first child that goes to that school, and anything that's new just takes a little bit of work and time and training to get your head
Yeah.
around.
Absolutely. And then there's another question here around using pumps for blended diet. So, um, there are a few kind of pumps coming on the market now that are, designed for a blended diet. And at the moment, families are having to self-fund those. So, um, do you have experience of using those pumps in particular, or using any sort of pumps for continuous feeding or anything like that with the blended diet?
So I wouldn't recommend using blended diet with continuous feeding, because then it's going to be out of the fridge for a
Hmm.
long time. So then it's going to be in that danger zone. We've got risk of bugs growing in it. So really, if you're using a pump, you'd be using it in the way of administering a bolus using a pump. Um,
Yeah.
I do know the pumps that you're talking about. I have had a play around with them. They do work with blended diets. But yeah, accessing them is tricky in the NHS system. And that it's just the way that the home enteral feeding service in the UK has evolved over the years. It's all packaged in, isn't it, with the care providers. Um,
Yeah, and
so
I suppose we're kind of locked into contracts and things like that, with certain
yeah,
feeding companies, depending on where you work. And potentially if we were doing this webinar in maybe a year's time or 2 years' time, those pumps might be available on the NHS. I suppose we don't really know what the trajectory of that is at the moment, maybe.
yeah, it's tricky to say.
Yeah, absolutely. Um, Okay, and so what about like specialized diets? So I work in a sort of a big tertiary hospital, so we see children who might be on a ketogenic diet or have sort of specialized metabolic, you know, dietary advice or exclusion diets. Would you kind of be a bit more cautious in that patient group, or would you still be like, let's give blends a go?
Yeah, so anything that you can, any adaptation you can make to the diet where you'd be prescribing it to an oral eater, you can also do to somebody who has a feeding tube. So the same foods that you'd be recommending and the same modifications you would advise, but then you're just blending those foods. With keto and with metabolic, it might be that you also have to use other products alongside, but it may be that those are those are the products that you would be prescribing to an oral eater as well to support them being able to follow that diet.
Okay. Um, Everyone, feel free to add any questions to the chat or to the question box as well. But if not, I'll just keep going with, with
Yeah.
questions that I have. Are there any foods that just do not blend well that, just cause a bit of an issue, maybe when parents are first starting out with the blended diet, and then causes a lot of anxiety around kind of making those blends?
Yeah, it tends to be raspberry seeds,
Okay.
are a culprit. Chia seeds as well can be problematic. Making sure that you're blending for long enough, as I said, can really help. If you're using a mid-range blender and those things are still kind of visible in the blends, the family might want to use a sieve. So we'd recommend a metal sieve with less than 1 millimeter holes. Um, and that can just be a
Mm.
little bit of a safety net as well that they can use to see that it's the right consistency. But another thing is the kind of really stodgy kind of pastas, anything really starchy that's been blended and then that for a few minutes it starts to thicken, and
Hmm.
that kind of thing really needs to be warm if it's going to go through. You can get away with kind of rinsing things like rice and pasta to get rid of some of the starch. I did have a family once who tried to blend gnocchi. That did not go well. I got a lovely picture of the blender with a load of gnocchi in it, and the mum had the blender completely upside down and it was just stuck in there. Um, so yeah, really starchy foods, but not most foods will blend.
Yeah. And
There
when
are
you're,
oh,
go on.
there are some tricks as well, like things like toasting the bread can help it or blending cereals dry as opposed to adding milk first that can help it go through.
No, that's really helpful. That's a good tip actually to know. And I suppose the whole idea is just to kind of demedicalize everything around eating, right? You know, everyone else is having spag bowl or fish fingers and chips and beans for dinner. You know, just stick that in the blender and pop it in the tube. Yeah.
Yeah, yeah, as much as you can, but shifting families from that mindset of having an enteral feed to having meals can be quite tricky, particularly if there are no other children in the family or they've never cooked for a child, can be a steep learning curve. Um, Everybody really seems to enjoy adding treats and adding different
Hmm.
foods. So we get lots of comments about birthday cakes, Christmas dinners, Advent chocolates, Easter eggs, like those kind of things, treats where tube-fed people have been kind of excluded before that they can suddenly include as well. And why not? Obviously, that we wouldn't want that to be the majority of the diet, and we want to kind of limit the sugary foods and things. But sliced birthday cake, it's important, isn't it? Not just for the nutrition.
Absolutely, absolutely. Got a few more questions come in now. So,
Yeah.
does the osmolarity of the blends have any importance? Is that anything that you kind of worry about, you know, for your patient group or when working with families on a blended diet?
Yeah. I mean, it would depend on the food ingredients that you're using, what's being
Mm,
used as the base of the blend as well. So it's probably very variable, and it would be difficult to manage. That does worry me in particular with jejunostomy feeding.
mm,
That's a worry that we're going to get some dumping, but that seems to be even the people who are jej fed who are on commercial feeds seem to have variation between individuals. So perhaps it's a personal tolerance thing as to whether
yeah.
that's going to be an issue.
And I suppose if you have a blend that's say predominantly, you know, pretty much all fructose, you're probably going to get lots of GI symptoms because it's pretty osmotic and
Mm.
depending on what the fruit is. And that would be the same if someone ate, say, a whole punnet of whatever if they were eating orally. So I suppose pragmatically, you might just take the same approach as if they were having symptoms with eating large volumes of those fruits and veggies orally.
Yeah.
Yeah. We've got another question from Anna. Should we as dietitians start talking about blended diet in the same security as oral eating? Wouldn't a change on speech and wording also help with build confidence and reassure providers, carers, guardians, and education settings around normalizing and not discriminating? I think you kind of already said that before, Sarah. Yeah.
Yeah. Even people who are on commercial enteral formulas, I think we can change some of the terminology to normalize feeding our tube.
Yeah, definitely. Okay. Um, Perfect. And any other questions from anyone else before we wrap up? There was a question about seeing the webinar afterwards. So yes, if you do want to kind of refer back to the webinar at, you know, any other time, this is recorded and it will be on YouTube at some stage. I'm not sure how quickly it comes on, but yes, it will be recorded. Um, would nut butters be a better option than raw nuts to blend?
Yeah. And really great if you're wanting to add calories and protein. So in the same way that, like we would give food fortification advice, things like nut butters are a great addition in there. You probably wouldn't want to go too high so that it was really sickly, but yeah, that but equally, if you're using a high-powered blender and you have raw nuts, you very quickly have nut butter. So it might be a cost consideration as well.
Absolutely. Okay. All right. Well, thank you so much, Sarah. That was fascinating. So we will have a follow-up session on the 10th of December, which will be focusing on the inpatient side of blended diet, so specifically about setting up a blended diet service. So I know where I work, that has been a very long and slow process, and I'm sure it's the same at many hospitals as well. So we need to think about these things from, both sides, from the community setting and from the acute setting, so that we can kind of keep these patients on the diet that works best for them in any situation that they found themselves in. But yes, so if you have any other questions, I'm sure you can drop Espghan office an email and she can send them out to Sarah, if she needs to. But yes, thank you everyone for attending this evening. Thank you. Bye-bye.
Thank you.
Thanks, Sarah.
Thanks. Bye.
Bye-bye.